Now, this is where it starts to get fun. So now we're going to go deep into the primary assessment. All right, so I need you to lock in with me. And even if you're watching the replay, I want you to talk back with me, okay? If I ask a question, I want you to talk back out loud, say it out loud. That's how it's going to reinforce the information in your head. And for those of you on live, make sure that you're typing in the chat for me. Make sure you're still responding. I've got everybody muted now, but I can see your mouths moving. So make sure that you're still responding with me, okay? All right, let's jump into it. Now, when it comes to the primary assessment, this is one of the most important things for you to know. So I'm going to teach probably the most important concept right up front, okay? Let's go right into that. If you'll notice here, this picture, you notice a brain. So what you see is a picture of a brain. Let me shrink that up a little. Okay, so you see a brain, you see a picture of the heart and lungs, and then you see the kidneys, okay? And notice how I have them arranged. So on the top, I have the brain, then the heart and lungs, then the kidney. There's a reason for this. The most important organ in the whole body, everything that we do in medicine is to protect the brain. I mean everything, okay? Then it's making sure that the heart and lungs stay good, and then followed by the kidney. So here's what I want you to know. Rule number one, in terms of the most important concept in medicine, everything we do is trying to protect the brain. Why? The brain is the most sensitive of the organs. It's the most sensitive to hypoxia or a lack of oxygen. The brain has to have two things all the time. Number one is it has to have oxygen. Okay. Number two is the brain has to have glucose. Okay. Now, the heart's primary fuel source is not glucose. The heart is a muscle that's beating every day, every minute, every second of your whole life. So the heart actually uses free fatty acids as its primary source. So on the other hand, though, the brain, its primary source of energy is glucose. So this is why if the blood glucose gets low, this is why very quickly the patient will have signs and symptoms of altered mental status. They'll be confused, they'll be sleepy, drowsy, things like that. It's because they have to have a constant supply of blood glucose going to the brain all the time. So this is why whenever there's altered mental status, one of the first vital signs that we want to check is glucose. Okay? This is also why, if they have signs and symptoms of altered mental status, it's so important that we make sure they're oxygenated well. It literally comes down to how does the body normally work? The brain normally works off glucose and oxygen. So we need to make sure it has a steady supply of glucose and oxygen. Now, the next most important organ is the heart. So we'll say heart and lungs, but it's so heart. And then finally followed by the kidney. So what I want you to know is in most important to least important, it's going to be brain, then heart, then kidneys. But when it comes to what gets sacrificed first, when things go wrong, it actually goes in reverse. So one of the first things that goes wrong when somebody has let's say a severe illness or a chronic disease, one of the first things that goes wrong is their kidneys, okay? So they'll have a lot of renal type symptoms because that's one of the first organs that starts to suffer. Then after the kidneys die off, the next thing that dies off is the heart, and then finally the brain. Now, when we do CPR on somebody, what are we actually trying to do? It's called CPR, so cardiopulmonary resuscitation. And when you look at CPR, let's pop that back on the screen for a moment. When you look at CPR, so cardio and then pulmonary resuscitation, it seems like you're trying to resuscitate or revive the heart and the lungs. No, not at all. The reason we're doing chest compressions is so that we get blood flow to the brain, okay? Because in that blood is going to be nutrients like glucose and other nutrients. There's also going to be oxygen being transported in the blood. And we're really trying to get blood to the brain. So when we do CPR, it's all about protecting the brain, okay? Even though it's called cardiopulmonary resuscitation, we're trying to resuscitate those things so that ultimately things go to the brain. Does that make sense? First important or most important concept right up front is the brain. Everything we do is to protect the brain. Now, how can I prove it? You remember how we were talking about in the primary assessment? It's so we're going to do our here. Let's go back to it for just a second so you can see it. In our primary assessment, remember here how we have C-spine, general impression, chief complaint, apparent life threats, level of consciousness, airway, breathing, circulation. And I just said, what's the most important organ again? Talk back to me. What's the most important organ? It's the brain. Now check this out. Because when we do C-spine, that happens to deal with the what? That happens to deal with the brain. When we're assessing level of consciousness, that has to deal with what? The brain. Their level of consciousness is dealing with the brain. When we're talking about the airway, it's not so much that we care about the airway. Yes, we care about the airway. Don't misunderstand what I'm saying. But the reason we care about the airway is because we want a passageway of oxygen to go so that air can ultimately get where? To the brain. When we talk about their breathing, there again, it's about oxygen, them staying oxygenated well so that air ultimately gets to the brain. And when it comes to circulation, we need blood flow. Yes, we need blood flow to the heart because the heart is the muscle that has to pump the blood to the rest of the body. So the heart is selfish, it wants its own blood. But ultimately, we need to make sure that blood goes to the brain. Because if the heart has blood, but the brain does not, the heart may actually still beat for a little while, but they'll be brain dead. Okay. So much of what we do in medicine comes down to protecting the brain. Okay. That's just a different way to kind of present it. Now, let's go back to where I was. I love making these connections in real time like that. Okay. Now, you don't have this in your notes, but I want you to just kind of follow along with me. Here's what I want to show. This is the next most important concept. Everything in medicine comes down to the cell. So a lot of what we focus on is we're focusing on all these meds and procedures and stuff like that. But everything that we do in healthcare really comes down to we're trying to change something that's happening at the level of the cell. Okay? So here's what I want you to see. Here's our cell. Now, I'm not going to go deep into cell physiology, but what I want you to notice is some basic stuff of the cell. We got the cell, we got the nucleus, we got the nucleolus, we got this mitochondria here. I want to point out this mitochondria. There's a reason I'm pointing this out. You've probably learned it as the powerhouse of the cell and all of that. What I want you to know is the body spends all day, every day trying to keep you alive, trying to make energy. And that energy comes in the form of something called ATP. We're not going to get lost in the weeds here. I want you to understand a big picture concept. That big picture concept is one of the components of the cell is the mitochondria. Its job is to make ATP. But we need ATP for everything. And here's what I want you to know. Once we don't have enough oxygen in the bloodstream, the body can't make ATP. Once the blood is not flowing, the body can't make ATP. So anytime you have a problem with oxygen or anytime you have a problem with ventilation, ultimately it's going to affect ATP. And when we don't have enough ATP, the cells die. When enough cells die, you die. Okay? So everything we do in medicine really comes down to the cell itself. Remember how I said that the brain, it needs two primary things all the time. Number one, it needs oxygen. And then number two, it needs glucose. So anytime we don't have enough glucose running in the bloodstream, it can cause problems like altered mental status. Anytime we don't have enough oxygen, there again, it can cause things like altered mental status. Here's what I want you to see. This is a pattern that will apply over the entire body. The first most important concept I just went over was that the brain is the most important organ. Remember number one? What's number one? Most important organ is the brain, followed by the heart, then followed by the kidneys. But when it comes to sacrifice, the first organ to get sacrificed is the kidney, then the heart, and then the brain. Okay? Concept number 2 I want you to know, though, is anytime we don't have enough oxygen, the first thing that happens is we set off this whole alarm called ischemia. So ischemia is where we have a lack of blood flow. Now, hypoxia or hypoxemia is where we have a lack of oxygenated blood flow. This is what I want you to know. And this happens in the brain, the heart, the kidneys, the lungs. It happens in every single organ in the entire body. Anytime we have a lack of blood flow, we're going to have ischemia. But that ischemia is going to cause the cells to become injured. Now, sometimes when the cells get injured, we have what's called reversible cell death. This is why we're doing things like airway, breathing, circulation, because we're trying to figure out what can we correct while things are still reversible. So when your patient starts getting sick, hopefully you catch them when they're still in a reversible state, because if they progress from sick and they go from compensated to uncompensated, then they can go to what's called irreversible cell death. And then now we have the cell is dead and it's permanently dead. And now we have things like necrosis happening where the cell is dead forever. So every time we have a lack of oxygen in the body, we set off this whole cascade that is ischemia, then injury, reversible cell death, irreversible cell death, and we always have inflammation. So this is why in every chronic situation known to man, let's say congestive heart failure, diabetes, pancreatitis, myositis, any kind of itis, in every chronic condition that every patient has, there is some degree of cellular swelling, okay? And I'm not going to go further into that for this class. I want you to just kind of see the big picture of what's happening to your patient. And this is why you want to be so aggressive with things like oxygenation, because it will set off this whole path of events that starts to happen. That's about all I want to say at this stage. All right, let's keep going. Now, this is the next. So far, we've already covered the first most important concept, which was what? What's the most important organ? Type it in the chat. Okay. Most important organ is going to be the brain, followed by heart, followed by kidney. When it comes to the order they get damaged or compromised, first one that gets taken out is the kidneys, then the heart, then the brain. Then I said that we're doing everything possible to keep the cells alive. And we always want to make sure the cells have oxygen. We always want to make sure the cells have glucose. Now, this brings us to our third big concept for today. Here's what I want you to see. When it comes to oxygen, so let's just do a quick review. When it comes, let's blow this up for you. You're going to breathe in air. So you're going to breathe in oxygen, and that oxygen is going to go in, and it's now going to go into your lungs, right? But after it gets into your lungs, it's going to go all the way down to the alveoli. What do we know about the alveoli? What happens there? It's the site of what? It's the site of gas exchange. And now, what gases get exchanged? Like, what gases switch places at the alveoli or at the junction between the alveoli and the capillary? Those gases are what? Okay, those gases are going to be oxygen and CO2. So at the alveoli, that's the site of gas exchange. And then at the capillary, that's where this oxygen now gets into the bloodstream. Now, this same oxygen that went through the lungs, through the alveoli, across that alveolar capillary membrane, gets into the bloodstream. Now it's going to go to the tissues. And there, things are going to switch places. And so we're going to have a waste product called carbon dioxide. And that carbon dioxide now is going to go back through the bloodstream, cross back over the capillary alveolar membrane, go out the lungs, and then you're going to breathe out the carbon dioxide. So here's what you need to know. The oxygen goes in, the carbon dioxide goes out. Now, this looks like a really simple concept. However, This is one of the most important things in all of medicine. I want you to know these two words: oxygenation versus ventilation. Now, a lot of people, when it comes to the National Registry and in real life, a lot of people miss this very important concept. All right, lean in with me. Lean in. Okay, this is the most important thing I'm going to probably tell you today. If you know nothing else, you must know this concept. Two words that I just gave you. What were those two words? All right, type them in the chat.
Oxygenation and ventilation.
Okay, oxygenation and ventilation. Okay, cool. Here's what I need you to know. Oxygen, only oxygen fixes an oxygenation problem. However, a lot of your patients have a ventilation problem. Now, ventilation is primarily dealing with getting rid of all this carbon dioxide, and I'll tell you why on the next slide. What I want you to know for now is only oxygen, or oxygen only fixes oxygenation problems. Oxygen does not fix ventilation problems. Okay? So if you think that you need to give, let's say you have a patient in respiratory, let's say you have a patient in respiratory distress, and then they progress to respiratory failure. Respiratory failure is a ventilation problem where they're not adequately getting rid of the carbon dioxide. Okay, and I'm gonna show you why that's so important and so critical to be able to recognize. Just giving them oxygen, so let's say you put them on a non-rebreather mask and you blow that non-rebreather mask and load them up with oxygen at, let's say, 12 to 15 liters per minute. That does nothing if they have a ventilation problem. All you did is put oxygen in, but they still have all this carbon dioxide that's trapped that can't get out. Okay? What you need to know is oxygen does not fix a ventilation problem. Every patient in respiratory failure has a ventilation problem. So every patient in respiratory failure must be ventilated, not just given oxygen. Let me say that again. Every patient in respiratory failure, the fix for that is some kind of ventilation, not just oxygenation. Okay? So if you just put a non-rebreather on a patient who's in respiratory failure, you actually cause harm to this patient. I'm not saying they don't need oxygen. I'm saying they don't only need oxygen. Okay? Now, how do we fix oxygenation problems? We're going to use a nasal cannula, a non-rebreather, a nebulizer, venturi mask, things like that. Okay, let's talk about a nasal cannula. How's it going to flow? What kind of flow rate are we going to use for a nasal cannula? All right, so generally for most nasal cannulas, it's going to be 1 to 6 liters per minute. However, if it's one of those capnography nasal cannulas, anybody know the highest amount that can flow through a capnography nasal cannula? All right, that's going to be 5 liters per minute. So for a nasal cannula, it's going to be generally 1 to 6 liters per minute. However, if it's one with capnography, it's going to be 1 to 5 liters per minute. Okay, so we'll just say capno. Okay, now for a non-rebreather, some books will say 10 to 15 liters per minute. Some will say 12 to 15 liters per minute. For a nebulizer, what kind of flow rate are we going to flow that through? Or flow through that nebulizer. So that's generally going to be 1 to a maximum of 8 liters per minute. So I generally set the nebulizer to about 6 liters per minute. Okay. We don't want to blow that aerosolized medication out too fast because then it just goes into the air. So generally, you're going to be safe at about 6 liters per minute with a small volume nebulizer treatment. Now, a lot of services may or may not use Venturi mask. That's one of those that, especially for those COPD patients, it gives a very precise. You swap out the adapter, and it's able to give a very precise concentration of oxygen. But the way we fix oxygenation issues is with some kind of oxygen delivery device like a nasal cannula, a non-rebreather, nebulizer, things like that. On the other hand, the way we fix ventilation problems, our number one tool is going to be a BVM. Now, this is so important. This is one of the biggest concepts that trips people up on the national registry? They use like a non-rebreather when they should be using a BVM. How do you know? How do you recognize ventilation issues? So here's what we're going to do. I want you to go to, let me swap documents real quick. I want you to go to your worksheet for today. Here, let me shrink that over so you can see it. All right. So I'm on the worksheet, and we're just kind of going to go through some of this really quickly. Let me start at the top. So remember the most important questions to ask. Number one is the scene safe? So of course, that's going to also deal with BSI, that kind of thing. So BSI, scene safety. Now, when it comes to sick or not sick, and I'm going to go through some of that, you really want to know very quickly, is this patient sick or not sick? Now, here's a rule that I want to tell you right away. If your patient is sick, you need to take care of life threats right away, and then you need to transport. If you have a sick patient, you must know this for National Registry. It also applies in real life, but it definitely applies on registry. For National Registry, if you have a patient that's sick, we're going to handle life threats, and then we're going to transport. If we have a patient that's sick, life threats, then transport. We don't do further assessment, okay? Make sure you know that. Now, we want to figure out what's going to kill the patient first. Well, problem with their airway, problem with their breathing, problem with their circulation. If they have altered mental status, if any of these are going on, we would say that this patient is sick. So if they have airway compromise, if they have inadequate breathing, if they have some kind of circulation problem, okay? On your worksheet, there's a sentence I want you to fill out. The NREMT wants you to fix. Anybody have an idea? The NREMT wants you to fix life threats before continuing to assess the patient, okay? You want to fix life threats before we continue further assessment. Now, when do you stop assessing the patient and treat? So that's kind of what I was just saying. If there's a problem with the airway, if they have inadequate breathing, if they have signs and symptoms of shock, altered mental status, life-threatening bleeding, we want to fix all of those things before we go any further. Okay, let me get to, there's a part I was trying to get to. We'll come back to this. Now, when it comes to recognizing if somebody is sick, so figuring out if there's some kind of immediate life threat. Let's talk about the airway, and then I'll come back to the part about ventilation. That's where I was, but let me just go in order for you. When it comes to the airway, some things that you want to assess very quickly. Are they speaking normally or not? Okay? When you listen to them, do they sound like a normal person is speaking or not? Okay? Now, sometimes their speech is abnormal. Maybe they don't have teeth in their mouth, or maybe they've had a stroke and they have some kind of speech deficits. Maybe they just have some kind of other cognitive delay where they don't normally speak well. Or maybe they're normally nonverbal due to some other situation. So we want to kind of figure out, okay, their speech right now, is this normal? Is this how they normally talk? Yes or no? If we have gurgling, so that's some kind of fluid in the airway, how are we going to fix that? So gurgling, immediately we need to suction the airway. How are we going to do that? We can use like a rigid or a hard suction like the Youngcower suction. We will suction. Remember, we're going to suction on our way out for no more than 15 seconds. So generally, as a rule for pediatric, we'll say about 10 seconds for peds, about 15 seconds for adults, no more than that. Now, anybody know why we don't suction more than, let's say, 10 to 15 seconds? Remember that rule I was telling you about? That the most important organ is the brain, and it's so important that we keep oxygen and glucose going to the brain at all times. Well, here's the thing. When you suction for longer than 10 to 15 seconds, what you're doing is you're removing oxygen out of the airway. You're removing oxygen out of the lungs, out of the airway. So you're actually depleting them of oxygen. Does that make sense? And the other, okay, so not only can you cause hypoxia, remember what I just said? How when you have hypoxia, that leads to ischemia and that leads to all these other problems. You're going to see this pattern keep coming up over and over and over again. One of the reasons we don't do prolonged suctioning is because it can lead to ischemia. It can lead to ischemia, hypoxemia, hypoxia, that can lead to all these other problems. The other thing that it can do is it can actually trigger a baroreceptor reflex called a vagal maneuver or a vagal response, and it can cause the parasympathetic nervous system to get activated. It can low heart rate, things like that. Now, why is that? Why is that important to know? Because if we lower the heart rate, let's say in a kid, their heart rate is naturally a little higher. Let's say we lower their heart rate. Now we don't have as much blood flow. And if we don't have as much blood flow, we don't have as much oxygen flowing in the blood, and we don't have as much sugar flowing in the blood. See how why I said it's so important that you know that big picture concept? Everything comes down to the brain. Everything comes down to oxygen and glucose being transported in the blood, right? Because that keeps the brain happy. See how it just keeps building on itself? Let's keep going. All right, let's go back to the. So, if we have gurgling, we're going to do suctioning. If we have snoring, how would we handle that? So, if we have some kind of snoring issue, what's the problem there? Somebody tell me. All right, type it in the chat. What's the problem that's causing the snoring? Okay, it's probably going to be the tongue. So, let me go to something real quick. So, remember, everything comes down to the brain and everything comes down to keeping oxygen and glucose flowing, right? So, if we have a patient with snoring respirations, what's more than likely happening is the tongue is being blocked, okay, due to the position of their head or the size of their neck, obstructive sleep apnea, whatever the cause may be, the airway is actually getting blocked due to the tongue. So, how are we going to open that airway? And by the way, every drawing, every picture you see, these are all my drawings. I've literally hand drawn every one of these images that you see. So, hope you like it. Hope you don't make fun of my drawings, but it's all there to help you learn. So, one of the biggest maneuvers we're going to do, what's this one called? All right, that's our head tilt chin lift. The reason we do a head tilt chin lift, there again, is so that we can open the airway so that oxygen can get in through the lungs, through that alveoli, into that capillary, across that membrane, and then eventually make it to the tissues. Okay. And when we make it to the tissues, we make it to the organs, one of the big organs being the brain. So we want to keep that airway open with the head tilt chin lift so that oxygen gets to the brain. Sometimes, though, especially in a trauma situation, we're going to have to open that airway with a jaw thrust. Now, how do we do that? We're just going to come behind the angle of the jaw and we're going to push the mandible, the lower jaw, we're going to push it forward. So if the patient is laying on their back, we're going to push it up. If their patient is standing up, we're going to push it forward, but we're always pushing it anteriorly. However the patient is positioned, it always goes anterior. Okay? So ways that we deal with snoring respirations is with a head tilt chin lift or a jaw thrust. Ways that we deal with gurgling, that's where we're going to take our suction. There again, how long are we going to use it? No more than 10 seconds for kids, no more than 15 seconds. Why do we not suction more than that? Tell me again. Somebody tell me. Why do we not suction for more than 10 to 15 seconds? Did I say minutes? For 10 to 15 seconds? Because we're not trying to suck out all the oxygen out of the airway, and we also don't want to activate the parasympathetic nervous system, causing the heart rate to go down because that's going to decrease the amount of oxygen and glucose going to the brain. Got it? All right. Now, what if they have, for instance, something like stridor? What is stridor, by the way? So stridor is a sound that we hear when there's a closure or a constriction or a narrowing of the upper airway. So what you want to remember is stridor. So stridor, I got multiple screens here. I forget which one I'm looking at. So stridor is an upper airway obstruction. It can be caused by trauma. It can be caused by burns to the airway. It can be caused by, let's say, a bacterial infection, a viral infection. Lots of things can cause it. But what you want to know is there's a sound that you hear. If you hear this, there again, this patient is sick. If any of these things are going on, this patient is very sick. Now, what if they're unable to protect their own airway? Okay, let me go back to the iPad. Some things that we want to do if they're unable to protect their airway, for instance, their tongue keeps falling and blocking the airway, some things we can use are like our oropharyngeal airway, our OPA. We can use our NPA. How do we measure the OPA? All right, mouth it to me so I can see what you're saying. All right, we're going to measure the OPA. So here's what I want you to know. The OPA, where does it go in? It goes in the mouth. The NPA, it goes in the nose. So from wherever it goes into, you measure from there to, some books will say the corner of the jaw or the earlobe. I mean, these are pretty close together. Just for simplicity, let's just say the earlobe. So for instance, if I'm putting in an OPA, I'm going to measure from the corner of the mouth, since it goes in the mouth, to the earlobe. If I'm putting in an NPA, I'm going to measure from the nair to the earlobe. Okay. Now, because of the way the NPA is shaped, which side do we put it in mostly? Okay. Because of the way the bevel is shaped, we want to normally try to put it in the right side first. However, sometimes because of their anatomy or because of a blockage or sinus situation, whatever, it may not be able to adequately relieve the obstruction on the right side. So then we put it in the left side. Of course, we're going to lubricate it because we don't want to cause more trauma. Yes, it's floppy and flexible, but we still want to take that little KY jelly and just kind of lubricate the tip of it really quickly. But look, if somebody's airway is compromised, we ain't got time to go find the KY jelly. So what you can do is, if their mouth is already open, just kind of stick it in their mouth, wet it, use their own saliva. It's not going to hurt them. It's theirs. They have it every day, all day anyway. So just wet the tip of it with their own saliva and then insert it into the nostril. Okay. So now, what if they have, here, let's go back. What if they have excess secretions? All right. There again, we want to suction if they have any kind of vomiting. What you want to do is, if it's just a medical call. Now, if they're unresponsive, you don't know. You don't know, are they unresponsive because they had trauma and then they went unresponsive? Or did they have a medical situation and then they went unresponsive? We don't know. So if they're unresponsive, the safest thing is just to assume it's trauma. And in that case, what you want to do is make sure that the head stays in line, maintain inline cervical stabilization, and then just suction the airway. Okay. There again, we don't suction more than 10 to 15 seconds. Now, if you are able to turn them on their side, especially their left side in the left, what's that called? That's going to be the left lateral recumbent position, or sometimes it's called the left decubitus position. Sometimes it's called the recovery position. We turn them generally like on their left side so that the secretions can fall out. Now, why do we turn them on their left side versus their right side? Anybody know? Okay, and it kind of comes down to, let's see if I have a picture here. Let me just draw it really quickly. It kind of comes down to the way the airway is arranged. So if we go from the trachea, and we know that, what's that bifurcation called? The bifurcation is the little split where it goes off into the left side versus the right side. That little split is at the carina. So this little area right here, that's the carina. But we notice that the right, so this one here is the right main stem bronchus, and then this is the left. Because the right tends to be a little more straight, it's a lot easier for things to automatically go down into the right side and into the right lung. This is why also for you paramedics, or for those advanced who may be able to intubate, but any of the advanced providers who intubate, This is why when we intubate, we want to make sure that the tip of the ET tube doesn't go past the level of the carina, because it's easy for it to just go down into this right mainstem bronchus, okay? So the reason we put them on their left side is because it's going to be harder because of the angle here, the sharp angle, it's going to be harder for things to end up in the left lung, but it's very easy for things to end up in the right lung, okay? And we're trying not to cause them to aspirate, to cause aspiration pneumonia and that kind of thing. All right, let's keep going. Is this helping? Are we learning some stuff today? Yeah? Somebody tell me what you've learned so far. All right, hey, just for time, I'm gonna keep it moving because I got a few more things I want to cover. Now, so if we have any of these things happening, this immediately tells us this patient's sick. Any problem with the airway is an immediate life threat. We don't go past go. We must take care of this first. So if in your test question, they have a patient that's not speaking normally, they're gurgling, they're snoring, we have stridorous respirations, they're unable to protect their airway, any of that happening, we need to immediately take care of the airway. How are we going to take care of the airway? Maybe we're going to open it with a head tilt chin lift or jaw thrust. Maybe we're going to clear it with suctioning. Maybe we're going to keep it open with an airway adjunct, an OPA or an NPA, that kind of thing. Any problem there, they're sick. Sick patients, what do we do for them? We fix life threats first, then we do further assessment. So we mainly fix life threats, transport. We may not even finish the assessment at all. Okay, now let's talk about breathing. This is really important. Some things, yes, I said earlier that we're going to assess the rate, the rhythm, the depth, the work of breathing. So this is a really important topic to talk about. Remember I said the two biggest concepts you want to know? Well, I should add a third. It's oxygenation, ventilation, perfusion. Let's recap that. What's oxygenation? Oxygenation, somebody talk with me. All right, make sure you're mouthing with me or make sure you're answering me if you're watching the replay. Oxygenation is the amount of oxygen coming into the lungs. How do we fix oxygen problems? With oxygen, through an oxygen delivery device. If they have mild respiratory distress, our device of choice is probably going to be a nasal cannula. How many liters per minute are we going to use through the nasal cannula? It's going to be 1 to 6 liters per minute. A lot of your flow meters, some of them don't have a 1, so they'll actually start at 2. Well, we're going to go maybe 2, 4, 6. A lot of times I start them at 4, okay? And then I'll bump them up. If it's a regular nasal cannula, our flow rate is going to be 1 to 6 liters per minute. What about if it's a nasal cannula with capnography? What's our maximum there? Talk back to me. Type it in the chat. Okay, that's going to be 5. Okay, what about if it's a non-rebreather? What's our maximum? Typically, that's going to be 15 liters per minute. Some books will say 10 to 15. Some books will say 12 to 15, but up to 15 liters per minute. All of those fix oxygenation problems, not ventilation problems. Now, here's what I want you to notice. If you see any of this in your test question, oh, I'm sorry, I'm not on the screen. If you see any of this in your test question, let's say a respiratory rate less than 10, now, especially for an adult. Well, actually, this would apply to anybody. Let's say if you have a respiratory rate of 10, because what's a normal respiratory rate for an adult, for instance? It's going to be about 12 to 20 breaths per minute. What about for a kid? And it's really important that you also know vital signs for pediatrics. In fact, I just thought about it. I'm going to add a document for vital signs that has all the age groups. I'll add that to your portal, so that'll be there later today. I have the document already ready, but I just realized I didn't put it in the portal. I'll do that today. You definitely want to know vital signs. If we have a respiratory rate of less than 10, why is that dangerous? Well, remember, everything comes down to oxygen, and it comes down to keeping oxygen and glucose going to the brain, right? If we have a respiratory rate of less than 10, what's happening? Well, not only are we not getting enough oxygen in, we're not breathing in enough times to bring in more oxygen to get oxygen into the blood so it goes to the brain, right? But we're also not breathing out what? We're not breathing out carbon dioxide. Oh yeah, and this is what I wanted to show you. This is the other really important topic. Let me get back to that on my notes. Right here. This is another very, very important topic that I think a lot of people don't understand well enough, and it causes you to miss questions on a test. This will cause you to fail the test if you don't know this. This also causes people to die in real life. This is a really important concept. The reason all this CO2 is bad, the reason you have to get rid of all this CO2, all this carbon dioxide, well, number one, this carbon dioxide behaves like an acid in the body. So here, let's just go ahead and call it acid. Okay. So all this excess carbon dioxide behaves like an acid, and your body doesn't like to have all this acid laying around. When it comes to your pH, you've got a very narrow range that your body wants to keep your pH. Remember that range is 7.35 to 7.45. As the pH drops, what that means is we have more hydrogen in the bloodstream. And so as the pH gets lower, the acid gets higher. Okay. So as the pH drops, the acid level raises, or the amount of hydrogen goes up. But we have a very narrow range where we're trying to keep the pH. Your body doesn't like to be acidic at all. Here's what I want you to know. You don't have to, this is not an acid-based discussion for today, but what I want you to know is carbon dioxide behaves like an acid. We don't want to have all this acid laying around. The normal CO2 is 35 to 45 millimeters of mercury. We don't want too much CO2 though. One of the biggest indications that your patient is really sick is a very high CO2. Okay. When you have a high CO2 in your patient, it means they got a lot of acid hanging around. This is a very predictable sign, or a very big indicator that they have respiratory failure. Okay. They can't blow off the CO2. So you want to be using capnography as much as possible. You don't want to just use capnography for intubated patients. Every respiratory patient, you want to use capnography. But capnography, you should be using it on your chest pain patients. You should be using it on those asthma, which is a respiratory problem, but anaphylaxis, a patient that you think is in septic shock. Because the biggest concepts you want to know, here, let me write that down. We already talked about oxygenation and ventilation. And then the third thing that's most important is perfusion. Oxygenation, ventilation, and perfusion. Everything we do in medicine comes down to this. Okay. Oxygen. Do we have enough oxygen getting into the bloodstream? Ventilation. Are we getting rid of all that excess CO2? And perfusion. Are we actually sending the stuff where it needs to go? Okay. Do we have enough pressure? Do we have enough stuff in the blood? Do we have enough blood? All of that comes down to perfusion, so that oxygen and glucose and other nutrients get where they need to go, especially in the to the brain. Let me go back to this. When you have too much acid, so we're going to call that acidosis. Here's what happens though. Too much carbon dioxide in the body, or too much acidosis, is going to cause the blood vessels to stretch out, to widen. What do we call that? That's vasodilation. Okay. Now, here's what I want you to know. When we have too much acid, when the patient is not breathing well, and we have too much carbon dioxide, that's going to lead to vasodilation. Well, that vasodilation is going to lead to shock. Oh, sorry. Shock. Okay. Now, most people don't, or I meet a lot of people who haven't been taught this concept well. This is why, okay, let's bring it all home. So when we have a patient who's, check this out, when you have a patient who's breathing 10 times a minute, what's happening? If you have a patient that's breathing that low or that slow, they're having all this CO2 that's hanging out, right? Because they're not getting rid of it. So this patient who's breathing slow, who has all this CO2, is going to end up with vasodilation, is going to end up in shock. So your patient that you have a respiratory rate that low and you don't treat it aggressively, the end result of that is shock. All right. I want to make the connections for you. So, what is the fix for this? If you have a patient that's breathing really slow or breathing really fast, either way, we want to ventilate this patient. Now, this patient doesn't just need oxygen. So, in a test question, if you have a patient, they say you have a patient that's breathing slow, above 30 times a minute, under 10 times a minute, the answer is ventilation with a BVM. If they're breathing shallow, shallow is they're not taking a normal breath with a normal tidal volume. Here, let's see if I have that. Let me jump to that real quick. Are you learning something? Are we making some connections? Yeah? Okay, so let's go. Let me hold on. Let's get back to breathing. Here we go. Right here. Let's pop me up. So, if we have a patient this is a normal tidal volume. It's about 500 milliliters of air. If we have a patient that's breathing a normal tidal volume, they're breathing in enough air to make their chest rise. How do you know if they have normal tidal volume? Their chest rises. Okay? However, if they're breathing shallowly, this would be an example of shallow breaths. It's not enough to make the chest rise. And if it's not enough to make the chest rise, it's not enough to get oxygen all the way down to the alveoli. And if we don't get the oxygen in the alveoli, it doesn't cross that capillary membrane, it doesn't make it to the tissues, and we have no oxygenation, okay? So, I'm sorry, I keep going back and forth between the screens. If they have shallow breathing, they don't just need oxygen because there's nothing to help the CO2 release the CO2. So if they have shallow breathing, the fix for that is a BVM. If they have irregular breathing, now irregular breathing typically happens with something that's affecting the brain stem. So if we go here, remember I said the brain is so important? Well, if we go into the brain stem, so this first section of the brain stem, that's the midbrain, and then we have the pons, and then we have the medulla oblongata. So in the brain stem, that's where the respiratory center is. Well, if they have damage, if they don't have enough oxygen, it can actually start to affect the brain stem. Well, that's where your breathing center is. So now they can start having irregular breathing. They can have all sorts of breathing patterns. So they could have, for instance, like this kind of pattern. So that would be Biot's respirations. They could have maybe apneustic type breathing. They could have this really, really deep and fast breathing. That would be like Cheyne-Stokes breathing. I'm sorry, that's Kussmaul's. That would happen in DKA. You don't have to really know that for registry. What I want you to know is if they're not breathing in a normal way, where air is coming in, air is coming out, they're not taking really big breaths or really shallow breaths. I'm saying that's normal. Normally, they should not be taking really huge breaths or really shallow breaths. They should just take a normal breath. A normal breath makes the chest rise and fall. But if they don't have good chest rise and fall, we're going to say they're breathing abnormally. The fix for that is a BVM. Now, what if they're using their accessory muscles? If they're using their accessory muscles, that means they're really struggling to breathe. They're having to use extra muscles to help them breathe, right? Though they could be muscles in the neck, like the scalenes, the sternocleidomastoids. They could be muscles between the ribs, the intercostal muscles. They could be abdominal muscles. You don't normally need all those extra muscles to breathe, right? But if they're having to use those extra muscles, what it means is they're showing signs of fatigue. So in a test question, if you see something like they're having respiratory fatigue, they're using accessory muscles, alarm bells need to go off and say, ooh, wait a minute, respiratory fatigue, that's probably a sign of respiratory failure. Respiratory failure is a ventilation problem. The fix for that is a BVM, okay? So far, what I've said is If we have a low breathing rate, they need oxygen and BVM. If they have a super fast rate, they need oxygen and BVM. If they have shallow breathing, it's oxygen BVM. Irregular breathing, oxygen BVM. Poor chest rise, oxygen BVM. Now, notice that I'm saying oxygen BVM because we never just use a BVM without oxygen, right? That would be dangerous. We don't want to do that to your patient. Why do we not use a BVM without oxygen, by the way? Because when I squeeze that BVM without oxygen, how much oxygen is going into that BVM? Let me see, I have, oh, that's okay. So if I just squeeze the BVM and I don't have oxygen, I don't have the tubing connected to the oxygen tank, I'm just getting air out of the environment. And so that's roughly about 21% oxygen. We want to make sure it's connected and we want to make sure that it's turned on as high as it'll go. We want oxygen coming out of that tank, going through the tubing, going through the BVM, so they're getting as close to 100% as possible. We want to make sure that that bag inflates, the reservoir bag, because if the bag does not inflate, they don't have 100% oxygen. But all that extra oxygen is going into the bag. So we want to always make sure that the bag stays inflated the entire time. If you ever see that your bag is starting to deflate, well, you need to check your oxygen cylinder because you're probably out of oxygen at that point, okay? So what I just said is all of these situations are times where we need to use oxygen plus a BVM. Does that make sense, everybody? Now notice, if you see any one of these in your test question, slow respiratory rate, super fast respiratory rate, shallow breathing, irregular breathing, very labored breathing, use of accessory muscles. If we see any of that in our test question, we never just use a non-rebreather. Why? Because a non-rebreather only, remember, a non-rebreather fixes oxygen problems. But these are not oxygen problems. These are ventilation problems, and oxygen alone does not fix a ventilation problem. Does that make sense? Okay. So here's the biggest takeaway. If on a test question, you have a patient who is sick, they have some kind of trouble breathing, if you don't know the answer, BVM wins over just oxygen, okay? If you're down to 2 and it's BVM versus non-rebreather, pick BVM because the BVM will save a lot more lives than the non-rebreather will. Does that make sense? So what I want you to know is when in doubt, BVM beats oxygen. Now, obviously, you're always going to use oxygen with the BVM, but I'm saying BVM with oxygen beats oxygen by itself. Does that make sense? Okay, hopefully that makes sense. Now, we've just got about just a few minutes. We're going to hit circulation, and then we'll stop for today. This is a really big, important concept to know. Okay. And so we'll do part 2 on this tomorrow, but we're tying in a lot of things in just this one. When it comes to circulation, these are the most important things to know as the way to recognize signs and symptoms of shock. By the way, what is the difference between a sign? What is a sign versus a symptom? Okay. A sign is what you see. Okay. So if you can see it, if you can observe it, that's a sign. A symptom is what the patient says. Okay. Of course, if we're talking about what the patient is saying and if we're going to document it, we're always going to put that in quotes. As we document what the patient says. Here, so let's take away the quotes from here so we don't confuse you. A sign is what you can see or observe. A symptom is what the patient says. Whenever we say what the patient says, we put that directly in quotes when we document, okay? Hey, by the way, what would you think are the most common, what is the most common sign and symptom that you're going to see in an emergency situation? The most common around the world that makes somebody call 911. I want you to think about this. What did I say is the most important organ? Most important organ is the brain. Okay. What are the 3 biggest concepts that you must understand? Oxygenation, ventilation, perfusion, right? Now, the question I just asked is what are the most important, or I'm sorry, not most important, what are the most common signs and symptoms that make somebody call 911 anywhere or around the world? It's not 911, but whatever the emergency number is around the world, what is the most common reason somebody causes or calls for help? Okay. What's the most common symptom? What's the most common sign? So, sign versus symptom. When somebody calls 911 in the US, the most common symptom you're going to get is I can't breathe, shortness of breath, right? Because the reason they call 911 when you can't breathe is they're not getting enough oxygen or they're not ventilating well. Okay. The most common sign that you're going to observe, the word for that is dyspnea. So difficulty breathing. Okay. We were just talking about that. We just said that, let's go back. So we just said, hold on, right here. Okay. We just said signs, these are all signs of somebody having difficulty breathing. Specifically, this is difficulty breathing that has progressed to the form of respiratory failure, not just respiratory distress, but respiratory failure. What's our fix for respiratory failure signs? That's going to be a BVM with oxygen, right? For respiratory distress situations, that's typically an oxygenation problem. We fix that with oxygen. For respiratory failure, we're going to fix that with a BVM plus oxygen. Okay. So, what I want you to see is those same life threats that we just covered happens to be the most common symptom that causes people to seek help in an emergency. The other most common symptom around the world is going to be they say, I'm tired, I feel weak. Okay? They're going to say, I'm tired, I feel weak. Why does that cause them to call 911? Because when a lot of the reason they're tired is because they have an oxygenation problem or a ventilation problem. Remember how when you don't get enough oxygen or when you don't get rid of the CO2, that causes ischemia, that ischemia causes reversible cell death, or it can cause irreversible cell death. Well, if you have reversible cell death, if you have irreversible cell death, how does it make you feel? It makes you tired. It makes you weak. Because when you have, remember how I said this was the most important? Let me go back to this. Remember how I said that if you don't get enough oxygen to the cells, what happens is this mitochondria can't make ATP. That ATP is what you need for energy. Well, if you're not making ATP, you can't have energy. How are you going to feel? You're going to feel tired. You're going to be weak. Okay? So the next most common symptom is they're tired and weak. And so we're going to see that as we'll say malaise or fatigue. Okay? So, and think about this. Think about the next time you go on a call. How many of these calls you go on have something to do with shortness of breath, have something to do with being tired or fatigued? Now you're understanding why it's happening as opposed to just knowing what's happening. Does this make sense? I get so excited about making these connections. All right, now let's go back to the screen real quick, and then we're going to wrap it up for today. Some signs that you want to recognize of poor circulation. Number one is going to be hypotension. Well, I shouldn't say number one, because hypotension is actually a late sign. So when you're looking at on National Registry or even in real life, if you wait to the point of their blood pressure dropping, that's a really late sign that they're probably closer to irreversible damage at that point. Okay, not only have they had ischemia, they've had injury, but now they've probably passed the point of reversible damage and they may be in irreversible states of shock. So hypotension would be typically a very dangerous sign. But some other things to recognize for shock is tachycardia with symptoms. Now, when I say the reason I say it that way is just having tachycardia alone doesn't necessarily mean there's cause for concern. Okay? If I get up right now and I just run outside, if you put me on the monitor right now, I'm going to be tachycardic. My heart rate is going to be over 100 beats per minute. A normal heart rate is what? 60 to 100 beats per minute. However, I'm not having symptoms. There's no need for concern. That would be a normal physiological response. So we want to focus on tachycardia with symptoms, okay? So we'd call that symptomatic tachycardia. Just like for bradycardia, it's not just bradycardia that's a problem. So for instance, registry, a lot of times they'll show you, let's go back to me. So registry will show you vital signs, right? And people sometimes will get tripped up. They think because the heart rate is 120, that means you need to be doing something. But nothing else is wrong with the patient. Remember, we have to figure out, is the patient sick or not sick? Just because their vital signs are abnormal does not mean they're sick. On the other hand, just because their vital signs are normal does not mean they're not sick. In fact, you can very easily have quote unquote normal vital signs because your body is compensating, but you're actually very sick. Vital signs are something that we need to trend. Vital signs give us information about, like, are they getting better? Are they getting worse? But we don't just look at vital signs and say, oh, they're sick or not sick. Okay. Vital signs is supporting information that we're going to trend. How often are we going to trend our vitals? For critical patients, we're going to reassess a complete set of vitals every 5 minutes, sometimes even more often than that. In a critical care environment, in a helicopter or critical care transport, where a patient's blood pressure is dangerously low, their mean arterial pressure is low, we may have an ART line in where we're monitoring their blood pressure second by second, not just every 5 minutes. But at a minimum, for critical patients, you're going to reassess their vitals every 5 minutes. At a minimum, for stable patients, we're going to reassess their vitals every 15 minutes, okay? All right, I just want to finish this final thought about circulation, and then we're going to wrap it up for today and then hop over to VIP. I hope you're learning today. So we're going through this a little slowly because this is the most important stuff to know. Notice that in our buckets, we're in bucket number 2, but look how much stuff comes up in bucket number 2. Bucket number 2 is that primary assessment. The other thing that you want to look at for circulation and perfusion status is weak, thready pulses. If they mention anything about the pulses feeling a little weak, feeling kind of, sometimes they'll use the word thready. It just means that you, like when you put your fingers on their pulse, it's barely palpable. You can barely feel it. Now, by the way, what's the difference in a pulse and a heart rate? So this says pulse. Okay, a pulse is what you feel, a heart rate is what you measure. The machine, the monitor gives you a heart rate, or whether it's coming through, sometimes it measures through the blood pressure cuff, sometimes it measures through the pulse oximetry probe, sometimes it's measuring through the cardiac leads, however your monitor is set up. But the heart rate is what the machine gives us, the pulse is what we actually feel. By the way, when it comes to checking a pulse, you want to quickly figure out, and we're actually going to cover that tomorrow, but when it comes to checking a pulse, you want to check 3 things: the rate, the rhythm, the quality. The rate, is it normal, fast, or slow? The rhythm, is it regular or irregular? The quality, is it normal? Is it thready? Is it bounding? So here we're talking about weak, thready pulses. That's an indication of shock. If they have pale, cool, diaphoretic skin, all right, it's so important that you know normal. How should skin normally be? Well, skin should be pink, kind of pinkish color. Now, what if they're a darker complected person? Sorry. They're still parts of their body. Let's say you pull down their lower eyelids. That should still look kind of pinkish. You look at the oral mucosa in the mouth, that should look kind of pinkish. So, or maybe their palms of their hand, those areas should still look quote unquote pinkish compared to pale. Skin should normally be warm. As long as you have normal perfusion, you have good blood flow, skin should be warm, right? Skin should be dry. Okay? So if you have somebody who's diaphoretic, they're in some kind of sympathetic state. Now, and the reason I say that is right now, I want you to do something right this second. make your heart rate go up. Okay, if I move around right now, if I start breathing faster, my heart rate goes up. Make your breathing rate go up. Same thing. If I start moving around, doing things like that, I can make my breathing rate go up. So I can change the physiology of my breathing and my heart rate. Here's what I want you to do. I want you to sweat right now. Go. Sweat. Now, but you're not, right? So the thing is, if you're sitting around sweating, now obviously if you're sweating because you've been outside, it's been hot, that's your body's natural mechanism to try to keep you cool, that makes sense. But if they're just sitting in a chair and they're sweating and you can't normally just make yourself sweat on demand, that's something you need to really pay attention to. So if you have a patient that's kind of diaphoretic, you need to be on hyper alert to say, "Ooh, wait a minute, this is not normal. They're sitting down at rest and they're sweating. Hey, this patient's probably in a state of shock. We need to aggressively treat this. This is a life threat. This is a load and go situation. We need to aggressively move," okay? If they have, pale, cool, diaphoretic skin, and if they have delayed cap refill. So especially in those pediatric patients, we want to make sure we're really assessing cap refill. We're going to squeeze the nail beds. It should go from when you squeeze it, it kind of it causes this vasoconstriction to happen, and blood kind of leaves the area, and so the skin, the nail bed, kind of gets pale, kind of whitish color. But very quickly, within about 2 seconds, the blood flow should return to that area, and it should pinken up again. So the color should go from like normal to abnormal back to normal in about 2 seconds. But if it takes longer than about 4 seconds, we're going to say they have delayed cap refill. This is especially important to assess in those pediatric patients. Yes, you can assess cap refill in any patient. It's just sometimes it's not as reliable in adults because maybe they smoke, maybe they've been outside, maybe they're homeless, maybe they have hypothermia, maybe they have other conditions like Raynaud disease or something like that. But capillary refill is something to check. Definitely check it on your pediatric patients. And then if we have uncontrolled bleeding, if we have any of this going on, this is a sign of shock. What I want you to know is any of this, any problems with their circulation is a sign of shock until proven otherwise. Okay. And I said we might go just a few minutes today because we had the introductory stuff. So let me just show you what we've covered today. So let me pop something up on the screen real quick. So just today, look how much we've covered, guys. Today, we were talking about the patient encounter. And I said there are how many buckets? There are 5 buckets. What I want you to know is bucket number 1 is our scene size up bucket. We always take care of things out of bucket number 1 before we go to bucket number 2. When it comes to bucket number 2, that's going to be our primary assessment. We handle C-spine. We form our general impression. In our general impression, we want to very quickly figure out, is this patient sick or not sick? To figure that out, we're going to further assess things involving their airway, breathing, circulation. Okay. We're going to assess their level of consciousness using AFPU. We assess their airway, breathing, circulation. We look for disability and exposure, and we'll pick that up tomorrow. Now, anytime we have any problem with airway, breathing, circulation, level of consciousness, any of these are what we call life threats. Any problem here, we say this patient is sick. Any patient who is sick, we must treat whatever the problem is at this step before we go on to another step, okay? If you will know just this one thing, just what we've covered so far today, you could probably get about 70% of passing registry with just that. So some things that we covered today is, remember we said the most important organ is the brain. Talk back to me. Answer me quickly. The most important organ is the brain, followed by the heart, then followed by the kidneys. When it comes to what gets sacrificed first, it's going to be kidney, then heart, then brain. Everything comes down to the brain. We have to keep what going to the brain at all times. Number 1, we got to keep blood flow with oxygen and glucose. If we have a situation where we don't have enough oxygen, the brain suffers. We have things like altered mental status. If we don't have enough glucose, the brain suffers. We have altered mental status. So what you want to know is in every altered mental status patient, You need to be checking a glucose. You also need to be making sure they're adequately oxygenated. Just because their SAT is normal, does that mean they're adequately oxygenated? No. They can have a normal SAT. Remember, we talked about how you can have carbon monoxide poisoning. Your SAT is 100. You're not oxygenating well at all. So we don't just focus on the SAT, we focus on the patient. And remember that the cellular physiology thing that I did with the boxes? The first thing that happens is we have hypoxia or ischemia. Then that leads to injury, that leads to inflammation, it leads to reversible cell death, and then irreversible cell death. And then finally, it leads to things like necrosis, right? This is what's happening in every cell in the body. This is why oxygenation is so important. This is why ventilation is so important. We said that to fix oxygen problems, we give oxygen through a nasal cannula, non-rebreather, venturi mask, nebulizer, things like that. Nasal cannula, how are we going to deliver that? That's going to be normally 1 to 6 liters per minute. If it's a nasal cannula with capnography, it's how much? That's going to be 1 to 5 liters per minute with a max of 5. A nebulizer, how much oxygen? That's going to be typically about 6 to 8 liters per minute. If you don't know, go with 6. That's a nice, safe bet. A non-rebreather, what's the flow rate? I know this is repetition, but that's how we cement these concepts. These are basic concepts, but if you'll know this, you've picked up a lot of points right there on your exam. A non-rebreather, that's going to be either 10 to 15 liters per minute or sometimes 12 to 15 liters per minute. Okay. Now, all of those fix oxygenation problems. But the bigger problem that happens in a lot of situations is a ventilation problem. A ventilation problem is where we have too much CO2. When we have too much CO2, what's that condition called? Acidosis. What does acidosis lead to? Acidosis leads to vasodilation. Vasodilation leads to? Vasodilation leads to shock. So the reason we don't want to just give oxygen when they have a ventilation problem is they're going to ultimately end up in shock. See how we're tying all this together? How do we fix ventilation problems? Our number one thing is oxygen with a BVM. How do we tell that we need to use a BVM? Respiratory rate less than 10, respiratory rate greater than 30, inadequate chest rise, shallow breathing, irregular breathing. If they have use of accessory muscles, if they're really fatigued, things like that. How do we recognize that there's some kind of circulatory problem or shock? It could be, come on, let's go, hypotension, but is that an early or late sign? That's going to be a late sign. Okay, what else? Tachycardia, but is it just tachycardia? No, it's tachycardia with symptoms. What else? It could be delayed cap refill. It could be uncontrolled bleeding. What's another thing that would tell us there's a circulatory compromise? What else did we say? Okay, that's going to be weak, thready pulses. All right, so we have covered so much today just by knowing how to properly do a scene size up and how to do a thorough primary assessment. So we're going to end that now today. So what's going to happen now is for those of you in VIP, I'll see you in just a moment. For those of you in general admission, it's been a pleasure having you today. I hope you've learned a lot. I'm about to end this chat. For those of you in VIP, what I want you to do is go to your email or just hop on over to your portal. There will be a link there to be able to access the next Zoom session. We'll start in just about 2 minutes. Let me just end one. Let me pull up the next Zoom session, and I'll see you in just a few minutes. Have an amazing day, everybody. See you tomorrow.